Megan, you want to start us off?
Absolutely. So hi, everyone. My name is Megan Kennedy. For those who don't know me, I am the archivist here at the college. I'm going to give you a really brief update on what the archives has been up to the last year. So our mission in the archives is to advance the goals of the college by acquiring, preserving, and providing access to records of enduring value. And essentially, that's a fancy way of saying that we gather information that tells the story of the college from its founding and before, all the way up to present day. So just a little comparison of our activities over the past year. You can see that our research requests have gone up quite a bit this year, and I think that's due to two different things. One, we have a couple college anniversary projects that are really exciting, I'll talk about in the next slide. And the other thing is, I think a lot of people have been home because of COVID and have been digging into their past and their family histories. We've had a lot of members of the general public reaching out to us and asking information about their loved ones who were fellows of the college, which has been fun to help them with. In-person visits, predictably, are very low. We still technically aren't allowing outside researchers in, and the couple that we have been directly related to those anniversary projects. But hopefully, as things continue to improve with COVID, we can start introducing that option back to our researchers. Accessions have gone down considerably as well, and the main reason for this is because in 2019, the college had our big remodeling project, and a lot of desks and closets were unearthed, and things were transferred to us that have been lost for quite a while. So we took in a lot of material in 2019 that obviously didn't continue into the new year. So our activities in the archives are kind of in three different categories. The first is the archives website. We are constantly updating the website with new information. The History and Archives Committee activities are the thing we update the most. We are always updating our Congress activities, the different programs we do, our panel session, our history of surgery posters. We're always updating those things each year after Congress and throughout the year as we carry on different activities. We also update our 25th and 50th anniversary pages. So these are for our fellows who are celebrating 25 years and 50 years each year at Clinical Congress. It's a really cool site. If you haven't seen it, I suggest to check it out. We put up photos, videos if we have them. We scan all of the Clinical Congress news and convocation programs for our fellows. So they can go online and reminisce about their fellowship year. And, you know, if you aren't one of those anniversary fellows, it's still fun to go and see what Congress looked like those years ago. Also on the website, we have our surgical education modules, which was a major project spearheaded by the Surgical History Group, which is what we were called before the History and Archives Committee. These are different modules in surgical history, and they cover a variety of different topics. A lot of our members put a lot of work into gathering those, and they're all available on the archives website here at fax.org/archives. So in terms of collection care and administration in archives, we are always processing backlog. It's an archivist's favorite thing to do, and we're constantly trying to get our material that we receive cataloged and accessible to researchers who are looking for it. So we're always doing that, getting new information into the archives catalog and updating those systems. We also do a lot of remote reference, emphasis on the remote the past year and a half, and have been working on how we convert this meeting and last year's Congress to virtual meetings, which has been quite a feat, but I think we've done a good job. We also are always maintaining, updating, improving our archives catalog and our searching capabilities within it. So this past year, we migrated to a new system. It's very similar to our previous catalog, but it just has some more advanced searching features. There's faceting now, so if you are looking for something and you know it's a photograph, or you know you're looking for a document or a video, it's a lot easier to narrow the results down to those different items. So in terms of outreach, two things that we'll talk about in a minute, the Fellowship of Surgeons Biography database. We also produced a book, Black Surgeons and Surgery in America, this year, and Dr. Nakayama is going to be talking about that in a minute. And I've also, as I mentioned, been doing a lot of work on anniversary celebrations. So the Committee on Trauma and Commission on Cancer are both celebrating their 100th anniversaries in early 2022. So we've been doing a lot of work in the archives, gathering information, photographs, anything to help them tell their story of their centennial coming up in the new year. So very briefly, the Fellowship of Surgeons biography project I mentioned. This was inspired by a project that the Royal College of Surgeons in London does. And essentially they have a huge database of their deceased fellows that they have biographies for. And this is from all the way from the early fellows of the college up until present day. So they're collecting new people every month. So we thought this would be a great way to feature our fellows a little bit more. And to get the project started, we started with a pilot of just our past presidents. And we finished that, I believe it was in June of this year. So each past president has a biography uploaded into this database. And you can see this is the main page of it. We have featured some fellows. They all have their name, dates of birth and death, and specialties listed. And then you can click on any of these fellows and it'll take you into a more detailed biography as well as a nice photo. You can also search the database by name, city, any type of metadata you have about these people you can search. And this year we're going to be focusing on our officers and regents as the next pilot project. So we're hoping that this is successful. We'd encourage everybody to go on ACS or fax.org/archives, and you can go into the catalog, and you'll see a link for this biography project in the catalog. Let us know if you have any comments or questions. We're always looking for ways to improve it and get feedback on whether people are enjoying the project or not. And with that, I'm going to send it back over to Dr. Pappas.
Thanks, Megan. Next slide. I'm just going to briefly give everyone an update about what the committee has been up to. I think if you haven't signed on recently or been a participant, you may have missed the fact that we are now a committee, the History and Archive Committee. We used to be a group, and so we're a committee like a lot of other committees at the college. And you'll find us if you get on the website. You can find us on the committee page and on the community page also. Next slide. This is just a listing of our executive committee and our committee chairs. And you'll hear in a minute that we do need some new members of committees. I'll mention that at the end, but this is the current leadership group. Next slide. And this is sort of the full docket of our roster, which gives the committee chairs, and then the members of the different committees. And it's not a large group. I will highlight Dr. Lamar McGinnis, who has the special title of Emeritus Member, because he was basically the individual who created this group by generating an interest with the college. And we always thank Dr. McGinnis for all of his efforts. Next slide. Our group does support a lot of projects, particularly articles. Some of these articles appear in the Bulletin of the American College of Surgeons. This is just a listing of some that came out in the last couple of years on a variety of surgery history topics. Next slide. This is what we're sponsoring this year at the college. The main session is our panel session that we're sponsoring, the Rude Unhinging of the Machinery of Life, the Surgical History of Shock. That is airing on Wednesday at 9 a.m. October 27th. We have 3 great speakers, so that'll be something that you'll want to tune into. There's a live chat question function that'll occur during those tape sessions. Then we have, of course, our poster session that'll be aired beginning at 8 a.m. on the 23rd. You'll hear a little bit more about our poster winners in a minute. We also help sponsor the Drake Lecture, which is the evolution of modern day spine surgery, conflicts, compromise, and collaboration. That'll be airing on October 25th at 1 p.m. And the Churchill lecturer this year will be Dr. Alan Kirk, first doctor, last doctor, airing October 26th at 9 a.m. So those are the events that we are either sponsoring or co-sponsoring. Just as a reminder, again, if you enjoy reading some interesting blogs every week, that we usually have something up every week. Don Nakayama is one of the main contributors, but some of us others contribute also, and there's a lot of discussion that you'll read on that website. So we average about 700 to 800, 855 this year members, community members that participate. Lots of discussion and responses for those blogs. So it's an interesting post or interesting reading if you get a chance. We have been having a archives fellowship that we sponsor every year. It's a $2,000 grant for 1 year for one person. It was postponed this year because of the travel restrictions. Usually the individual who is the recipient of that grant gives a little talk at this breakfast. But since we did not have it because of COVID last year, hopefully we'll be having that again next year. Just as the kind of meetings that we run otherwise, the executive committee and the committee chairs meet usually once a year live at the Congress. Hopefully we'll be in San Diego, but we've been meeting by Zoom for the last couple of years. And then there are usually some meetings along the way, 2 and 4 Zooms during the year where we get together and discuss various topics. Again, we have some subcommittee openings on the archives committee, the program committee, the bylaws committee, and the outreach committee. So if there are anyone interested and you're a fellow of the college, we'd be more than happy to have you participate and apply. We're interested in individuals from a variety of diverse backgrounds. So anybody who's interested, please let us know. Those will open up in October of 2022. Don Nakayama, I think it's up to you.
Thanks, Ted. Megan, can I have the next slide? We have 2 publications coming out of the committee. One is this publication, which is Black Surgeons and Surgery in America. It's a multi-author compendium that came out of a general sense that the college needed to know something about that's passed with regard to Black surgeons and the practice of surgery by Blacks in America to inform decisions that were going on at present. So this is will be coming out toward the end of the month. It's available on electronic basis, free through the college website, and for a modest fee that covers publication expenses only through the college bookstore. Next slide. Gordon Talford has got a really exciting project. This is his book on Franklin Martin, and it's a different spin on Dr. Martin, who's the foundational figure of the college, that focuses on his boyhood and his upbringing in rural Wisconsin. Remember that Martin founded the journal Surgery, Gynecology, and Obstetrics, the forerunner of the Journal of the American College of Surgeons, in 1905. He initiated a clinical congress of the Surgeons of North America in 1910, which grew to be the Clinical Congress of the American College of Surgeons, and the organization itself in 1913. And all of these entities are very strong today. According to Dr. Talford, the book provides insight into the impact of his early years in Wisconsin on those later accomplishments. And it hypothesizes that wasn't despite his rural upbringing that he became a great leader. It was because of it. And so we're excited to have this book come out. It's going to come out sometime later this year, early next, and we'll be excited to read it. So, great. So I turn it back over to you, Ted.
Now, Patrick's going to give us an update on this year's poster session, which I think was very successful.
Thank you, Ted. Thank you, everybody. It's a real honor to be participating in yet another breakfast at the ACS, virtually at least. I'm a trauma surgeon, so every meal is potentially breakfast for me. This has been another outstanding year. Thanks to Megan Kennedy for seamlessly putting this all together, apparently effortlessly. I'm sure it takes a tremendous amount of work. She spearheaded this great poster session. We've got a total of 37 e-posters who are graded and found to be of exceptional quality that are going to be available for, or if not, they are already available for your perusal. Strongly recommend that you take a look at them. As one of the judges, I can tell you, it just seems to get harder every year to pick 2 or 3 really good ones. However, this year, the winners, I want to start with the second place winner, in my opinion, still a winner. John Becker's outstanding presentation on the right to operate, an example of medical censorship for political affiliation during the McCarthy era, was a really in-depth look at that particular subject, very well put together. But the overall favorite was Dr. or rather Ms. Allison Oliva and Dr. Barr and Chicken's contribution. Beecher's bombshell, how one man's article revolutionized medical and surgical ethics. Very, very timely, very, very well done. Not surprisingly, and both of those are going to be available for you to look at. Again, congratulations to the winners.
Thank you very much. And now, without further ado, our featured speaker, and I'd like to just give a brief introduction for Dr. Jones. Dr. David S. Jones is our featured speaker. Dr. Jones is a professor of epidemiology at the Harvard School of Public Health and the Ackerman Professor of the Culture of Medicine at Harvard University in Boston. He's a psychiatrist by training, and his PhD is in the history of science. He studied a variety of topics, including the causes and meaning of health inequalities, and he has a significant interest in decision-makings in cardiac therapeutics. He's currently studying the evolution of coronary artery surgery, both in the US and abroad. I should mention that Dr. Jones's middle initial is S. It stands for Shumway, and I asked him about the possible coincidence that his middle name has, and he admits that he has a distant genetic tie to the history of heart surgery in the United States. The title of Dr. Jones's talk is When Surgery is an Experiment, Lessons from the History of Surgical Treatment of Coronary Artery Disease. Dr. Jones.
Let me just get my slides up for all of you to see. That should have done the trick. Well, thank you very much for the invitation to speak with you at breakfast this evening. As Ted said, I'm a psychiatrist and a historian. And so I come to surgery, the history of surgery, as a bit of an outsider. And it's been very helpful for me to be able to engage with people like Justin Barr and Peter Kernahan, who can give me the surgeon's perspective on the history of surgery. And I also want to make the plug for how important archives are for anyone who's interested in doing this work. Much of the work I'm doing tonight is based on the archives of Elliot Cutler, which are held at the County Library of Medicine in Boston. I had the very good fortune to get access to this collection. It had a 80-year privacy wall on it that opened up in 2017. And so I think I was the first and only person so far to be able to look in detail at Cutler's papers, which are a stupendous collection for people who are interested in the history of surgery. Now, as many of you know, the field of cardiac surgery was transformed by coronary artery bypass grafting. Since the 1960s, that technique has changed the role, the work, and the financial prospects of cardiac surgery. I suspect many of you are familiar with the basic aspects of this history. What I want to do tonight is to revisit this history and tell some stories that I hope will be less familiar to you. These stories will reveal the challenges of surgical innovation and research. As long as patients seek relief for their symptoms, which I think they always will do, and as long as surgeons think that a better treatment might exist, which I also think they always will do, then surgeons are at a risk of crossing a line between medical care and surgical experimentation. So tonight I'll describe several cases from the early history of surgical treatments for coronary artery disease, in which surgeons took extraordinary risks with their patients and were startlingly willing to believe that their interventions had worked. And I have every reason to believe that surgeons face similar risks in their work today. Now, many histories of revascularization start with the work of Alexis Carell. He was responsible for pioneering many of the key techniques of vascular surgery, developing countless techniques. He's most famous for his work on transplants, but he also performed at least 2 attempts at coronary artery bypass grafts, both of which were unsuccessful. He had tried them both in a dog, trying to do the anastomoses on a beating heart, and he could not succeed and have the dog survive the operation. He had presented this work widely at both the New York Academy of Medicine and the American Surgical Association. He published accounts of his bypass attempts in Medical Record and in Annals of Surgery. He received celebratory press coverage in the New York Times. And I think, but haven't figured out yet how to prove, that Carell's failures at these 2 attempts discouraged other surgeons from trying. And so the procedure itself received little interest again until the 1930s and 1940s. The early surgeons who did try to treat coronary disease through surgery took very different approaches. One approach sought to relieve the pain of angina pectoris by disrupting the innervation to the heart. Charles Mayo, as far as I can tell, went first, although he's rarely credited for this. He described a patient in 1913 who was a major in the Army who'd had to give up his work in the Army because of intractable angina. In 1913, Mayo described he removed both sympathetics, that is the middle and superior on both sides, and wholly relieved his pain. Now, despite the seemingly promising start, sympathectomy followed a complex course. One problem was that surgeons, and really no one at the time, did not understand the autonomic nervous system. There was no consensus, for instance, about the basic question of whether disrupting the sympathetic nerves would lead to dilation or constriction of the coronary arteries. Others didn't attempt or didn't hope to modify the coronary circulation. They simply hoped that by cutting the nerves, they would block the pain. But again, surgeons were not sure which of the nerves carried pain signals from the heart back to the brain. And others worried that if they blocked the transmission of pain signals, they might actually do harm to their patients. And this was based on this idea that angina was a useful warning for their patients, telling them that they were putting strain on their heart that their heart could not tolerate. And the fear was that if you block the transmission of this warning signal, you might precipitate severe cardiac damage. And so, for instance, you'll see many critiques of sympathectomy for the treatment of angina pectoris coming from a variety of prominent cardiologists. In this case, James Mackenzie, who is one of the pioneering British cardiologists, condemned sympathectomy in 1924. He wrote that when the surgeon is profoundly ignorant of the morbid condition for which he operates and of the functions of the structures which he mutilates, it is impossible to conceive anything more detrimental to progress. That's very strong language. Surgeons, however, were not deterred and continued to develop sympathectomy. So especially surgeons in Boston at both the Peter Bent Brigham and Mass General Hospital were very interested in this procedure. They had 2 goals. They hoped that some patients might actually benefit from the operation, and they also hoped that the operations would generate new knowledge. And Cutler himself was explicit about this in 1927, writing that even if these procedures fail ultimately to prove of great practical value in clinical medicine, the stimulation towards the study of cardiac pain and the proper innervation of the heart will have been of great value to the profession. So this was a case of well-intentioned surgery, but without understanding the underlying physiology of what they were trying to do. In this setting, every sympathectomy operation was literally an experiment. And it's not at all clear to me what patients understood of this dynamic. And I haven't yet been able to get a sense of this from the archives of the surgeons either at MGH or the Brigham, which provide vivid clinical detail, but no insight really into what kind of consent conversations, if any, they had with their patients. They would just tell patients they had this procedure. The patients generally seemed to consent without concern, and then they would proceed to do the operations. The second approach that became common at this time for the management of coronary disease was thyroidectomy. Now, physicians had long recognized a link between heart disease and thyroid disease. For instance, in 1925, Henry Christian, who was the first physician-in-chief at the Peterbilt Brigham Hospital, wondered whether induced myxedema would actually help cardiac patients. As he wrote, a lowered metabolic activity from thyroid deficiency may be a conservative process, a form of cardiac rest that is advantageous to the heart. Surgeons started off by performing partial thyroidectomies on patients who had both angina and known thyroid disease. But as they became more enthusiastic about the procedure, they proceeded from partial thyroidectomies to total thyroidectomies, and then from operating on patients with known thyroid disease to operating on people whom they believed had normal thyroid function. And the goal here was that you could remove a normal thyroid and modify cardiac activity. And as you can see in this letter from Cutler to Renee Laennec, Cutler considered this to be the surgery of the future, this idea that you could operate on one part of the body to alter the function of another part of the body. Now, the surgeons knew that this was a dangerous gambit, and they actively debated whether the benefits, relief of angina, were better than the side effects, profound myxedema. Surgeons were sometimes dismissive of these side effects that the patients reported. And so this is one of Cutler's publications. And as you can see, many of his patients reported cognitive side effects, problems with their memory, problems with their concentration after the surgery, which is something that is often seen in patients with myxedema. Cutler was pretty dismissive of this. As he explained, although most of them believe that they are slowed down mentally, we have difficulty in attributing this possible change to the imposed myxedema, but see it as rather the normal slowing down with age. Now, it'd be interesting to see how long after the surgery these patients were making their concepts of these complaints. I don't think they had actually aged significantly by the time of follow-up. And the other thing that's interesting to see is the team at the Brigham, this is both surgeons and cardiologists, this wasn't just simply the surgeons, were very eager to try to figure out which patients were the ones who would most benefit from thyroidectomy. And so essentially what they were trying to figure out is which of the patients had thyroid responsive heart disease. And so the cardiologists at the Brigham developed an interesting diagnostic test, an adrenaline challenge test, as you can see in this case from 1933. So what they would do is they would bring a patient into the cardiac lab and inject them with adrenaline to see what would happen. And in this case, you can see that they inject the adrenaline. Within 10 minutes, the patient had become tachycardic and hypertensive. And if you can read the fine handwriting on the side, develops terrific distress, precordial pain, radiating down the left arm that was unresponsive to nitrates and morphine. They had successfully induced, or not successfully, they had induced a heart attack in this patient as part of the effort to determine whether this person had thyroid responsive heart disease. And again, this demonstrates how willing elite doctors were to take risks with their patients. In this case, the diagnostic test was seen as positive. The patient did indeed have hormone responsive heart disease, and they whisked them off to the OR for a total thyroidectomy. Now, not all surgeons were enthusiastic about the procedure. One thing that they had recognized is to manage the myxedema, many of the patients had to be managed with thyroid extracts after surgery. And this left people like Alton Oshner and Michael DeBakey very skeptical. Patients needed so much thyroxine after surgery to alleviate the myxedema that they then developed recurrent angina pectoris. So Oshner and DeBakey concluded that you had really accomplished nothing by removing the thyroid and then replenishing the patient's thyroid hormones with thyroid extracts. Now, many other surgeons in the meantime were developing imaginative techniques that would bring new blood to the heart. Claude Beck was one of the most pioneering in this. He had trained at Hopkins, Yale, and Harvard with Halsted, Cushing, and Cutler. He had a very distinguished pedigree. And this was one of the techniques that he developed, what he called the Beck 1. And what you would do is you would abrade the epicardium and the pericardium with a burr of some sort. You would apply a tissue graft onto the heart, and then you would partially occlude the coronary sinus. He hoped that this would do two things. The collaterals that would form from the de-epicardialized heart and the tissue graft might improve distribution of blood throughout the heart, so the heart would be more uniformly perfused. And then by partially occluding the coronary sinus, he hoped that he would slow venous outflow, and that would improve oxygen extraction from the blood. I suspect the fluid dynamics of that are actually quite different from what he had intended. Another prominent early cardiac surgeon, Arthur Weinberg, working at McGill, developed a set of procedures in which he wrapped the heart in sponge or omentum. And this was based on various theories he had about the healing power of primordial tissues. And then he developed another procedure where he would dissect out the internal mammary artery or the internal thoracic artery and implant the bleeding end of that artery directly into the ventricle. So this wasn't an anastomosis onto the coronary arteries. He would just implant the vessel itself into the wall of the left ventricle, sometimes into the right ventricle, a much more difficult procedure. And he believed that the porous sinusoids that made up the capillary bed of the myocardium would absorb the blood that came gushing out of the implanted artery. Another surgeon, in this case in India, tried to replicate the anatomy of reptiles. Reptiles don't have coronary arteries. Instead, the myocardium is perfused from channels that carry blood directly from the chamber of the ventricle into the myocardium. So P.K. Sen used a needle to bore holes into the inner surface of the myocardium that might carry blood directly into the heart muscle. This became popular with some surgeons in North America, even though the underlying rationale here made little sense. Surgeons were concerned that a contractile tissue would not possibly be perfused by these little channels that you had embedded within them. Now, it is easy for us, with the benefit of hindsight, to criticize these surgeons for being too cavalier in their efforts to re-engineer human tissues, but we should not be so quick to judgment. These were some of the most elite surgeons working in North America. Many had done extensive animal studies before proceeding to human trials. Beck himself wrote explicitly about the need for careful surgical research as a precondition for any kind of human trial. They were also quite thoughtful about the different outcomes they could measure to demonstrate whether or not their procedures had worked. So they would ask whether the surgical procedure had brought about the desired mechanical rearrangement of tissues, something that you could usually see at the time of surgery. They wanted to make sure their patients survived the operation. They were curious about whether the procedure improved physiological measures of function. They wanted to know whether it relieved symptoms or improved the functional capacity of patients. And best of all, they wanted to know whether this would improve long-term survival, and could the procedures do any of these without creating adverse side effects. So if you look at their correspondence about patients, or if you look at their publications, you can see astonishing reports that suggest that these surgeries achieved outcomes that seemed to satisfy both surgeons and patients, results that are thoroughly puzzling to the modern reader. And so, for instance, Cutler noted that many of his sympathectomy patients substantially reduced their daily use of nitroglycerin, for instance, from 40 tablets a day down to just 1 or 2 tablets a day. He explained one patient felt so well after surgery that he took up smoking again, which was seen in a perverse way as a marker of surgical success. Surgeons studied their thyroid patients in great detail, trying to understand the impact of this procedure on the physiology, measuring electrocardiograms, blood flow velocity, exercise tolerance, skin temperature, venous pressure, work capacity. Work capacity often featured prominently in many of these reports. These surgeons were working during the Great Depression, and a patient's ability to return to work was a crucial endpoint for both patients and their surgeons. They also elicited social workers, and this was the group, the cardiology group at the Beth Israel Hospital, which joined their colleagues at the Brigham and MGH in experimenting especially with thyroidectomy. But they enlisted the social work department at the Beth Israel to examine the impact of surgery on the lives of their patients. They would send social workers out into the homes to do extensive surveys. This is one of their interview prompts that they would use. And they found that these patients after thyroidectomy found their lives to be more meaningful. They felt that they were less of a burden on their families. They had fewer hospitalizations, and they had more economic productivity. Some of my favorite outcome reports come from the work of Weinberg and McGill, who became a mentor for Donald Effler at Cleveland Clinic as Effler was becoming a cardiac surgeon. And so they have a robust correspondence that went back and forth between the two of them. And so, for instance, Weinberg describes how one of his patients who he had treated by wrapping a sponge around the heart had done well enough after surgery to return to his usual activity, which in this case involved spending a night with a woman he had picked up on the street and then getting involved in a fight, I think, with her pimp. As Weinberg wrote, the patient had improved sufficiently after the operation to return to work and do those things that led to his death. Effler saw the humor in this and wrote back saying, perhaps if you emphasize the effect of your operation on the libido, it might provoke more enthusiasm from our medical colleagues. When coronary angiography became available, first in Cleveland and then elsewhere, Weinberg was eager to use it to demonstrate some of his successes. In this case, Mason Sones at the Cleveland Clinic performed angiography on one of Weinberg's implant patients. And I don't think this is captured well on the still photographs that have been preserved. I suspect this would have been a more dramatic effect if you were watching the actual video angiography. But Sones interpreted this as clear-cut and uncompromising evidence of effective myocardial perfusion. And it wasn't just these enthusiasts and pioneers who were enthusiastic. The successful reports of Weinberg implants were apparently replicated by surgeons at the Peter Bent Brigham Hospital in Boston. This was a publication in the New England Journal of Medicine in the 1960s. They used angiography to show patent grafts that communicated with the native vessels. They measured improved myocardial lactate extraction, suggesting improved aerobic metabolism. And they claimed that the procedure had decreased the incidence of myocardial infarction in patients who had had the implants. Now, as I said, these outcomes are a mystery to me. The procedures, at least as we understand them now, should not have helped their patients that much. Now, when the surgeon said it relieved angina, it's relatively easy to shrug that off because angina seems to be a symptom that is very susceptible to placebo effects. But the surgeons also reported improvements in a series of physiological measures, and those are harder to dismiss and harder to understand. Were surgeons fudging their results? I don't think so. I've seen no evidence of deliberate fraud amongst any of them. Were they cherry picking which outcomes to report? That's possibly true. Many physicians have done that, whether consciously or unconsciously. Many people have said, well, this was just a placebo effect. That was the motivation behind one of Beecher's famous articles about surgery as a placebo effect. But I think that's a mischaracterization of what might have been happening. If you believe that placebos, inert pills, can induce psychophysiological changes, then it's easy to believe that these highly invasive procedures could have been much more powerful at inducing whatever psychophysiological changes a placebo can induce. And so there are many possible indirect mechanisms by which patients might have derived value from these procedures. As I said, it's very hard to understand what might have been happening to leave both patients and surgeons so enthusiastic about these procedures. And so the first question that comes up is, how can you understand this raft of surgical experimentation that took place from the 1920s into the 1960s? The surgeons clearly had unwarranted optimism in what their interventions would achieve. Weinberg somehow thought that wrapping a heart with a sponge or implanting the internal mammary artery into the ventricles would have these great effects. They seemed to be very eager to see and report positive outcomes in their patients' postoperative experiences, going so far as to minimize or dismiss the adverse outcomes that their patients clearly experienced. And they were quite willing to downplay concerns that are obvious to us in retrospect. For instance, in the case of coronary sinus occlusion, I'll come back to that later on. But I suspect that many of these factors, optimism, desire to see positive outcomes, willingness to downplay concerns, I suspect that many of these factors remain present in surgery as in all areas of medicine today. Now, these experiences with the early history of bypass surgery had a major impact on the development of CABG. So as I said, after Carell tries at least twice and fails with CABG in the 1910s, it didn't get much attention from surgeons really until the 1940s and 50s, when a bunch of different surgical research groups start practicing the technique in their animal research labs. And so, for instance, Michael DeBakey reviewed the literature as of 1964. He found that there were 12 to 14 labs in the country who were attempting coronary artery bypass grafts in humans. Overall, they had a 50% success rate. And so DeBakey's conclusion was that the procedure was not ready for prime time. Until surgeons could get a higher success rate, he did not think it should be used routinely in humans. But despite this, several other groups had in fact tried the procedure in humans. As best as I can tell, the first human attempt at a coronary artery bypass graft was done by a New York surgeon, Robert Getz. who tried a trick that Carell himself had recommended. So Carell had said it's too hard to do the anastomosis on a bleeding heart, but what you could do is you could use a tantalum ring and invert the end of the graft over the ring and just slip that into the artery and do what he called a sutureless anastomosis. So Goetz tried exactly this technique, but for a variety of reasons, he only published this as an addendum into a report of his experiments in the animal labs. And so I think the publication got very little attention, even though it was in the Journal of Thoracic and Cardiovascular Surgery. And his local cardiologists were furious that he had done this and refused to refer him any other patients. So for Goetz, it was just a one-off operation. A series of famous surgeons themselves did try the technique. David Sabiston in 1962, DeBakey's team in 1964, the Leningrad surgeon Kolosov in 1964. But in the case of DeBakey, he hadn't intended to perform this technique. As I said, he didn't think it was ready for human use, but was used to salvage a failed coronary endarterectomy. Sabiston may have intended to do the procedure, but the patient died 3 days after surgery from a stroke. The anastomosis site on the aorta had developed a huge thrombus. And so Sabiston, I think, concluded that the technique itself wasn't safe. Kolosov did a whole series of patients. And when he attempted to publish this in an American journal, essentially got sabotaged by the editor, Brian Blades, who sent his report to Effler for commentary. Effler said Kolosov had attempted the procedure in the absence of coronary angiography, and that was reckless. And so no one should try to do what Kolosov had done. Ironically, it was the Cleveland Clinic team that eventually does succeed with this technique, but through an unlikely path. Effler and then Rene Favaloro, who joined him from Argentina, had initially followed the lead of Weinberg, doing sponges and implants. They thought that the implants worked pretty well, but as Effler described, it was a messy procedure. The severed side branches bleed so furiously that literally the entire surgical team gets bathed with these tiny jets of blood. They tried endarterectomy, but had 30% mortality in their early series. So Favaloro develops what he calls a patch graft, or the Vista Dome approach, as an alternative to endarterectomy, expanding the lumen of the artery at the site of the obstruction. But as you might imagine, if you look at the number of stitches involved in this, it was not an easy operation. Favaloro described it as an acrobatic feat rather than a surgical procedure. But by 1967, Effler and Favaloro had become happy doing what they called hybrid procedures. They would do Weinberg implants into the left ventricle, and then they would do patches on the right coronary artery. And they found that this allowed them to treat many patients who had coronary disease. And so Effler and Favaloro believed that they had initiated a new era of surgery. And this was in 1967. Favaloro, however, had learned about saphenous vein bypass grafts from vascular surgeons who were using saphenous interposition grafts to treat renal artery stenosis. Favaloro was confident in his technique, his skills as a surgeon, so he skipped animal research altogether and proceeded straight to human trial, publishing his first results in April 1968, and the rest more or less, is history. There's obviously a long follow-up history to this, but I don't have time to go into that tonight. Instead, I want to describe several interesting things about this path towards successful research at Cleveland. Now, first, as had happened with sympathectomy and in many respects with thyroidectomy, the surgeons really did not have a clear idea of the underlying pathophysiology. There were major debates in the 1950s and 1960s about whether coronary disease should be considered, or coronary atherosclerosis should be considered a focal or a diffuse process. In the early to mid 1960s, when the Cleveland Clinic team was focused on Weinberg implants, they would look at angiograms and conclude that the coronary disease was diffuse. And so therefore, the only way to treat the disease was to use this indirect technique. You couldn't rely on the coronary arteries themselves because the disease was too diffuse. And so, for instance, in 1963, Effler condemned the concept of endarterectomy. He said the overwhelming majority of patients studied with selective coronary arteriography demonstrate a diffuse pattern of coronary atherosclerosis. It is unlikely that the direct surgical approach will offer relief when multiple obstructions have occurred. It was only after Favaloro gets good at doing coronary bypass procedures does the Cleveland Clinic team begin to emphasize the focal nature of the disease. Another interesting aspect of this was their approach to risk management. As I said, when Favaloro began doing coronary bypasses, he did it in the absence of practicing on animals first. Had he done so, he would likely never have tried in humans because, as DeBakey had found, doing cabbage on animals, and Carell had found, doing cabbage on animals is very difficult. So to start off, Favaloro only began operating on the right coronary artery, figuring that if the procedure failed, the patients at least wouldn't die from the procedure. And third, as it happened before, the surgeons proved very willing to downplay the side effects. They had known from prior history of using heart-lung machines on valve repairs that putting a patient on a heart-lung machine carried a significant risk of neurological complications. But it took a decade before the Cleveland Clinic team did any serious work to try to understand the neurological risks experienced by their bypass patients. And once they did document a significant stroke rate from the procedure, they weren't really concerned, writing that the stroke risk was acceptable because they believed that they were saving lives. And it's also interesting to see the ways in which surgeons' own historical knowledge often left them skeptical. So Charles Bailey, who was an early cardiac surgeon pioneer and a proponent of endarterectomy, was very critical of the Cleveland Clinic team. When the Cleveland team presented their results at a surgical conference in 1970, Bailey got up and in the question and answer period said, 3 years ago, Effler was describing patch grafts as the next best thing to sexual intercourse. Today, he will tell you it wasn't so good. So the question really is, what will we think of saphenous vein grafts 3 years from now? Well, so one question that comes up is, why did the procedure catch on so quickly? Favaloro publishes his first report by 1968. By 1970, scores of surgeons are doing thousands of procedures a year. By 1977, surgeons are doing 100,000 cabbage procedures in the US alone. Now, the early surgeons celebrated that cabbage relieved angina, but they knew from history that relief of angina was not a reliable marker of success. Part of the appeal was currently something about surgical aesthetics. Bypass procedure was simpler and easier to do than either the implants or the vistadomes. There were no spurting jets of blood as in implants, and it was not an acrobatic feat as with the vistadome. Some of the appeal was visual, especially the evidence from angiography. As Effler wrote, arteriographic proof that the pathological ligature has been removed effectively and myocardial perfusion has been restored is prima facie evidence that the needs of that particular individual have been met. Yes, in this case, they were right. Coronary artery bypass grafting is a good procedure, but it still demonstrates the dangerous dynamics that are at the heart of surgical innovation. Now, one question that you might ask is whether this history and its lessons are relics of an older era, or do they have any relevance today? Surgical science certainly is far more advanced than it was in the past, and the ecology of cardiac care is radically different. In the early 20th century, there was no accepted standard of care for the management of coronary disease. Anyone with an idea, no matter how wacky, could take a crack at making a breakthrough. But now there is a dense network of treatments, behavioral, pharmacological, interventional, so the barrier of entry for a new innovation is much, much higher. And so you might think these factors would protect patients from unwarranted experimentation, and so that surgeons would be less likely to repeat some of these problems that came up in the past. And many surgeons have said so explicitly. In 1979, Wisconsin surgeon Lauren Bonchuk wrote an editorial in the New England Journal of Medicine to defend cabbage from its critics. As he wrote, modern medical therapy, meaning surgery in this case, is sufficiently sophisticated that only physiologically sound operations achieve wide use. But the recent history is not so clear-cut. Surgeons in the 1990s revived myocardial acupuncture, this time using lasers, not needles. But even though they had a cooler new technology, the technique did not improve the underlying rationale, which was deeply problematic, whether it was done in India in the 1960s or in Houston in the 1990s. And so, for instance, when the New England Journal of Medicine published 2 trials that reported favorable results from transmyocardial laser revascularization in 1999, it accompanied those articles with a hugely skeptical editorial that highlighted the role of placebo effects and the risk of researcher bias. Similarly, coronary sinus occlusion, pioneered by Beck in the 1930s, was revived again in 2004. Interventional cardiologists in this time published a sham-controlled randomized clinical trial in 2015 and found positive results, just like Beck had done in the 1930s. However, as the authors admitted, there was still no good rationale for the procedure, and their outcomes largely relied on subjective findings. And I suspect that most practicing surgeons could tell stories about treatments that exist now that they are skeptical about. This history helps us to understand why such treatments persist. Surgeons continue to be motivated by their desire to help patients. While treatments now are better than they were in the past, they are still imperfect. There is always a desire to develop something better. Surgeons are always willing to put their faith in optimistic physiological theories and are eager to report favorable results and are willing to downplay adverse effects. As long as these conditions exist, surgeons remain at risk of crossing the line between clinical care and surgical experiment. So let me stop my sharing so I can see all of you again. I'd be happy to take questions. I hope we have time to do so.
That was terrific. Thank you very much. We have time for questions. If you want to send them in the chat, or you can turn on your video, and if you want to ask the question, thoughts or comments. I have a question while people are getting warmed up. Tell us a little bit about your sources again. You mentioned it at the beginning, but if you could tell us a little bit about how you knew the availability of your resource from the Countway. How did it happen?
So that was really a case of dumb luck. The Countway has a large collection of personal papers, mostly of people either who had a connection to Harvard or just were in the Boston area that have been able to suck up a lot of these materials. And some of the collections have been widely used. So the Paul W. White papers, he was a cardiologist and a collaborator in a lot of the sympathectomy work that was done at MGH in the 1920s and 30s, had been available to researchers for a long time. And so I went to Countway to work on the White papers. And while I was there, I said, do you have anything by Cutler? And they said, yeah, we do. And they just opened up because they contain a lot of patient records. And because they have patient records, when the collection, the Countway's policies or anything that has patient records has an 80-year wall from the time that the collection was created. And so the Cutler papers had ended up at Countway in 1937. And so they sat there in boxes gathering dust until 2017. But archives provide a very important role by holding boxes as they collect dust for 80 years, because once that time limit has passed, then researchers have access. And it's a really terrific range of materials. So between the archives of White or Richardson, who was one of the surgeons at MGH, Sam Levine, who was a cardiologist at the Brigham, Cutler, there are papers from some of these characters who are at the Beth Israel. You see all sorts of things. So one of the things that are there are essentially Cutler's laboratory notebooks, or sorry, Levine's laboratory notebooks as they were doing these adrenaline challenge tests. And so there's record after record after record of what happened with these patients. They were often referring patients back and forth to each other. And so you can see patients who are seen at multiple institutions. Surgeons at MGH wouldn't want to do a procedure, so the patient would get referred to the Brigham. Cutler was extremely confident in his skill as a surgeon, so he would operate on more or less anyone if he was happy to do so. And the other thing that's great about this era of research for history of surgery, and you still see this in some journals, but a lot of the journals, when they would publish articles, were publishing articles that had been presented at national conferences. And someone was transcribing the commentary, the Q&A that would take place at these sessions. And so often you'll see the article from the researchers and then the commentary that had come up at the various surgical societies. And those aren't officially archival documents, but they're almost just as good. And you can really see the back and forth between surgeons in real time as they were arguing about these procedures. And one of the things that comes up quite clearly is that the place in Boston that had the most experience with thyroidectomy for thyroid disease was what is now the Leahy Clinic. Frankly, he was one of the outstanding thyroid surgeons. And so he had enormous experience with thyroidectomy at a time when the surgeons at the Brigham and the Beth Israel start doing thyroidectomy, and he was enormously skeptical. And so you can see these very interesting interactions between the various medical institutions in Boston. They were all watching what each other was doing. Sometimes they were reinforcing each other, and sometimes they were being quite critical. And so part of the problem is I have an enormously detailed manuscript sort of mapping the surgical community of Boston from 1925 to 1935 that I think would quickly exhaust the interest of any reader. And so that the challenge I face now is trying to figure out what 20% subset of this actually deserves to see the light of day. But it was really all made possible by these incredibly rich archival collections.
I think Dr. Barr has a question.
Yes, thanks, Dr. Jones, for another great talk. As always, I really enjoy your work, and I appreciate you speaking to our group. Yeah, in the beginning and the end, you mentioned that surgeons both in the 30s and 40s and today are at risk of sliding, experimenting on patients. Yeah, a counter argument is that if you don't push those boundaries, then care never changes, and that's exactly what academic surgeons like Cutler et al. Should be doing, is pushing those boundaries in a manner that is somehow ethical and safe for patients. So how do you distinguish between, accepting the status quo and not experimenting, but not pushing care forward, versus putting patients at risk by attempting therapies that are not necessarily based by level 1 evidence at the time?
Yeah, so I think the key thing was your second to the last sentence, which is how do you do so? How do you push the boundaries forward in a way that's careful and ethical? And which then raises this question of, who am I to reach back in history and judge these characters? What kind of retrospective ethical judgment is fair or appropriate? And so you could go through case by case of the various things that were done and likely make different assessments of which aspect of the work was appropriate and which aspects of the work might be problematic. So, one thing is a black box to me. As I said, I don't have much sense of what the consent conversations were like. So if they were telling these patients, look, you're in a rotten situation, and many of these patients would have been the first to admit that their lives were crippled by coronary disease. As far as I can tell, almost none of us now have seen patients living with a kind of intractable angina that seems to have been quite common 1930s, 1940s, 1950s. I remember talking to Fred Loop, who'd been the chair of cardiac surgery at Cleveland and was one of was involved early on in the Cleveland team when they were just launching CABG. He had said even over the course of his career, so between the late 60s and when he stopped operating, I think in the 1990s, atherosclerosis had become a much less virulent disease. And there are a variety of things that might be behind that. But these patients who were coming to surgery in the 1930s were incredibly sick, incredibly debilitated. And so it could be that the surgeons were forthright and said, look, we're really not sure, but are you willing to try because your life is miserable? And if that's what was going on, then maybe it was reckless, but it was reckless born of desperation on both patients and surgeons. And it'd be hard to have too much of a problem with that. But you would hope that surgeons would at least have some idea what it was that they were cutting before they cut into it. I remember as an undergraduate working in a surgical lab, and the fellows would tell me the first thing is don't cut anything you can't see. Don't close those scissors unless you have a full field of view of those scissor tips, which is good advice. They were cutting a lot of sympathetic nerves, and they didn't know what was in those nerve bundles that they were cutting, where they were going. And they would write explicitly that they hoped that by doing so, they would learn something. Well, it's important to learn something, but did patients understand how blind these procedures really were? And the other question I wonder about, and again, this is a subjective call, is what counts as a good source of innovation or good source of inspiration for surgical innovation? So when PK Sen says, I want to replicate the snake heart, reptile heart, and I'm going to try that in humans, that's an interesting idea. Is that a good enough idea to take a patient to the cardiac OR? Or Weinberg writes that his idea of wrapping hearts with sponge. I mean, he did these first procedures. He was using marine sponge, from the seafloor to do this. And he said the idea occurred to me one day at a South Atlantic beach when I was gazing out across the ocean and decided that somewhere into the depths of the ocean there must be a cure to coronary disease. Is that a good idea, or was this an acid trip of some sort? I have no idea what he was thinking, but he was willing to take that idea into the OR and make a homogeneous paste take a sponge, put it in a blender, make a paste, and then smear that paste on the surface of the heart. I think that's just reckless. I'd love to know what he was telling his patients. There's a case, and Justin, you'll have a better answer for this than I will probably. There's a question in the chat from Robert Nesbitt. Was the idea that atherosclerosis was segmental in coronaries recognized after it was known in peripheral arteries? Justin understands the history of peripheral vascular disease much better than I do. But I don't even know. I was just at a conference, a cardiology conference down in Texas this past weekend, and I was able to quite easily to prompt an argument amongst the cardiologists about even now whether they consider coronary atherosclerosis to be segmental or diffuse. And they'd say it depends on the patient. If you have diabetic patients, it's much more diffuse. And I'm sure there's a complicated story there. But what happened in the 1960s really seems to be a case of surgeons' interpretation of coronary angiograms depended on what operation they wanted to perform, which is a backwards way, I think, to go about doing this.
Thank you, Dr. Jones. I think we have one final question from Dr. Richard Lynn.
Thank you so much, Ted. Dr. Jones, this was an unbelievable presentation, and thank you. I guess just to carry the one step further, I was a first-year medical student under C. Walton Leahy when one morning I was working in his lab, and I was asked to get 2 dogs ready quickly at 5 o'clock in the morning because 2 people were coming with Dr. Leahy. They were Norm Shumway and, unbeknownst to me, Christian Barnard, a week after he did his transplant, to teach the professor, he was their teacher, how to do the transplant. So I guess my question to you is, with the whole advent of cardiac transplantation, was this just another extension of the same thing you've just exposed?
So I could talk for a great length about this. I've published a couple articles about this. So yes and no. Leahy is responsible for many great things and had the misfortune to sabotage his reputation late in his own career. But he created a system where Gibbon had developed a heart-lung machine that was incredibly complicated with the help of IBM engineers. Gibbon got scared off by the high operative mortality rates, bequeathed the technology to the group at Mayo, which figured out how to make it work. But Leahy realized that the world would not be able to replicate the skill and expertise that they had at Mayo. So Leahy, with his team, figures out a way to make heart-lung machines widely accessible. Someone, I think it was either Cooley or DeBakey, I think Cooley described Leahy as the person who brought the can opener to the cardiac surgery picnic. And what all those surgeons were able to do was tolerate extreme levels of surgical morbidity and mortality and push through until the point where they had made open heart surgery an acceptably safe and widely effective technique. And so there were lots of experimentation there. I think their patients understood the huge risks that were involved. And both in the cases that they would consent to these risks because of the dire situation in which they were living. Leahy is another interesting archive story. Leahy has a terrific archive at the University of Minnesota, along with the Wangenstein papers that really document well the history of this procedure. What I only found out at the end of 2 days of working with the Leahy papers is when his papers were still in his house, the house flooded. And so the collection had been underwater briefly and is now infiltrated with mold. And they had tried to remediate this, but it only came up at the end of the second day when I had a cough and a sore throat. And the archivist said, we should have mentioned this. Maybe you should have worn a mask when you were using these papers. So sometimes archival research has its own dangers. But you get this amazing glimpse. My introduction to Leahy had been the book, blanking on the title. It was
King of Hearts.
King of Hearts, which is both a celebration of his work, but also a bit of a muckraking book with a long exposition of his trial and diversion of funds to prostitutes and all of that. But then if you read Leahy's personal papers, you get a completely different vision of him as a man. And so, for instance, he publishes an account of the heart-lung machine in Scientific American around 1960 or so. And as far as I could tell, that then opened up a correspondence from high school students throughout the country. Now, this was an era of proud science fairs and lots of kids who were tinkerers. So there were lots of kids at high schools throughout the United States who were trying to develop their own heart-lung machines. Many of these kids in the Midwest had access to farm animals. And so they would write really high saying, you know, I've followed your diagram, I built this heart-lung machine. I was thinking of trying it out on a sheep. What do you think? And Lily would actually respond to some percentage of these. And he had some ability to judge who he thought was credible, who he didn't think was credible. Sometimes he would send spare parts, or he would send components that the kids hadn't been able to buy on themselves. He would generally advise them not to try it on large animals, but if you wanted to try it on a rabbit, sure, go ahead and do it. And you get this vision of a much more humane and thoughtful character than you get from King of Hearts. And so again, these archives can play many important roles for helping us understand these past figures.
Thank you so much.
Dr. Jones, on behalf of the entire group, I'd like to thank you for an absolutely stellar presentation. Thanks everyone for the questions and the participation. And I'll bring this to a close, and we hope everybody enjoys the college meeting next week. So thanks again to Dr. Jones and everybody else. Thank you.
Thank you so much. I'm sorry I couldn't join you in person.